that said, shall we, you want to go ahead and start your presentation?
Absolutely, yes. And I was wondering, since it seems that we are, I don't know how many people you see on the screen, but I only see 4 people, including the 2 of us. So should we just
Yeah.
go and introduce? Probably it's going to be easier, but we can just
Okay.
go and introduce each one. But
Yeah.
okay, let me see if you're able to see my slides adequately over there.
Yes, yes,
Okay.
yes.
So I'm gonna be the format here for Rachel and Valerie. So the format is I'm gonna go over very few slides, just really providing the big picture outline of ibrexafungerp, which is the antifungal that we are developing at Scynexis. And then most of the time is really dedicated for questions and answers. So whatever questions you have, I will be happy to address. I'm the Chief Medical Officer for Scynexis. My background, I'm infectious disease physician by training, and most of my about 20 something years in the pharma industry has been in really developing antifungal medications. So I have participated in the development of posaconazole, the prophylaxis indication, other antifungals that never saw approvals like albaconazole, several versions of itraconazole, and then finally right now with ibrexafungerp. We are the ibrexafungerp is a glucan synthase inhibitor. It is also known as SCY078 while we were developing the product. It belongs to a new class of antifungal agents. We call it the triterpenoid antifungal class because it has a triterpenoid structure. As you can see here, it's structurally quite distinct from the echinocandins, and you have here just an example of caspofungin structure, just for you to see what is the really big differences. And then, however, it really is targeting the same enzyme, which is the glucan synthase, but the interaction with the enzyme is in a different location, a slightly different location. And for that reason, some of the FKS mutations that confer resistance to the echinocandins, they do not seem to affect the MIC for ibrexa, where we have some of them that are common. So some of them that may confer resistance to the echinocandins may also confirm increased MICs for ibrexafungerp, but the great majority of the FKS mutations that have described that cause resistance to echinocandins do not affect ibrexa. It is orally bioavailable, so it is a much more smaller molecule, and that is what makes it different. The way, as Dr. Speck was mentioned, is somehow considered como the oral echinocandin. We are actually developing the IV formulation as well. We completed our phase 1 program. However, the IV formulation is substantially lagging behind in terms of the development program versus the oral formulation, which has already been approved for some indications and is being developed in phase 3 for other indications. In general, you will consider that ibrexafungerp has about the same activity that the echinocandins have, because every fungi that is susceptible to glucan synthase inhibition should be responding to both. So in general, it has great activity against Candida, including Candida auris, Aspergillus, Pneumocystis, Coccidioides, Histoplasma, Blastomyces. And then we recently reported activity also in Mucorales, so which was a little bit surprising, because certainly when you tested it from the purely in vitro point of view, the MIC seem to be quite high. However, in vivo, it seems to have some activity, in particular in combination. Ibrexa doesn't have any cross resistance with the azole resistant strains, so it's active against azole resistant strains and the majority of the echinocandin resistant strains as well. We have studied the product in more than 1,500 patients, and subjects have been exposed in different clinical trials. And the product has a low risk for drug-drug interactions, and it has a very extensive tissue distribution. This is probably a differentiating factor when comparing this product versus the echinocandins, because the echinocandins typically have a volume of distribution that is about 1, so which means that you get the same concentrations in plasma in the tissues. However, ibrexa distributes very, very extensively to the tissues, and often you exceed the concentrations in tissues versus in plasma. And then just giving you a high-level picture of what we are developing this product for, or what are our ongoing development programs. So oral ibrexafungerp is developing some hospital setting indications, including invasive candidiasis, refractory and resistant invasive fungal infections, and invasive aspergillosis. And invasive candidiasis, we are conducting one study that is called CARES, This is a study that has been ongoing for a couple of years and is specifically focused in patients with Candida auris infections. And we are about to start a study that we call Mario. It's a phase 3 study. It's a randomized double-blind control study in which oral ibrexafungerp is being evaluated as a step-down therapy from an IV echinocandin in patients with invasive candidiasis, and is being compared against oral fluconazole as a step-down therapy. So this study, we are in the startup process. We have the Fury study for many centers and many participants in this conference are participating in this study. This study is an open label study intended to provide ibrexafungerp as a treatment for patients which are refractory to other antifungal agents or cannot tolerate other antifungal agents. This particular study enrolls patients with Candida, Aspergillus, endemic mycosis, and now even mucormycosis. In some instances, combination therapy is allowed in this particular study as well. And then we are conducting a phase 2 study that we call Synergia, in which this is in patients with invasive pulmonary aspergillosis, in which oral ibrexafungerp is given in combination with a MOL activazole. In this particular study specifically is voriconazole. This is a phase 2 study in which we're aiming to really gather information regarding the potential magnitude of effect of the combination therapy. It's a double-blinded study, and it compares the combination therapy versus monotherapy with voriconazole. We're trying to understand what could be the magnitude of effect here to see and to guide the next stage of development, like could be phase 3. Then probably just to tell you what are all the different development programs that we have and where we are in the different development programs. So when are we planning to initiate and terminate and complete some of them? We also have one in the bottom of this slide, you can see here that we also have a development program that is focusing in another indication, which is vulvovaginal candidiasis. And for this particular development program, we already have the product approved under the name of Brexafem. We conducted 2 studies in acute vulvovaginal candidiasis, both of them completed and were the basis for the approval. We are conducting right now one phase 3 study in patients with recurrent vulvovaginal candidiasis, in which oral ibrexafungerp is given as a prevention of recurrence. We are completing that particular study. We are expecting to be able to file a supplemental NDA for this prevention of recurrent VVC this year, into potential approval towards the end of this year for this new indication. All the other programs that are focusing in hospital indications, as you can see here, you see the invasive candidiasis Mario study. We're planning to complete that study towards the end of 2023. Invasive pulmonary aspergillosis, we should be wrapping up that study by the end of this year. And the refractory invasive fungal diseases studies, which we include there Fury, which is for refractory fungal infections, and CARES, which is for Candida auris infections. We're planning to continue conducting these studies towards the end of 2023. As I mentioned, we completed the phase 1 for the IV formulation, and we're right now in discussions with the regulatory agencies regarding what are the next steps for the integrating the intravenous formulation into our development programs. So in general, our vision has been to really ibrexafungerp to be able to really having the opportunity to use it in community infections and also in hospital infections. And in community infections, because those studies are faster, easier to enroll, etc. So we have been able to complete one of our development programs there. And however, we continue developing the product for the hospital infections, as you could see. So with that, I think that these were my slides, just to really open the forum for questions, and happy to address any questions that you may have.
Thank you, David. That was very good. Anybody have any questions for David? If not, if they don't, then I have a couple of questions if they don't have any. So. All right. Well, maybe I'll start it off and they can have some. This actually has to do with, we're not talking about it today, but with the Brexafem that has approved. Mm-hmm. That is one single dose, right?
It is actually 2 doses in one single day. So we divided the dose, kind of a BID is 300 milligrams every 12 hours, only 2 doses. So it's 1 day, but it's 2 doses, 300 milligrams in the morning, 300 milligrams in the evening.
Okay.
Mhm.
I imagine Sobel had to do with a lot of those studies.
He participated in
So,
those studies as well, and he's really one of the authors of
yeah.
the publications. Both studies are published if someone is interested in looking at them. And the dose for that, just which could be interesting for you to know. So the total dose in single day for VVC is 600 milligrams, which is slightly lower to the dose that we are using in the invasive fungal disease infections, which is 750 milligrams given in 1 day.
Right.
So it's not so different, but it is slightly lower than the dose for VVC, and it's single day.
So we on occasion get, I don't see a lot of these except because they look me up on the internet and they see Candida or fungus, so they come to see me. So what about, are you doing any studies for refractory disease? Specifically, by the time they get to me, and this I think would be a perfect place for it. By the time they get to me, they've been on many topical antifungals, they've been on fluconazole, and they frequently end up with a Candida glabrata.
Sure.
That's multi-azole resistant. So do you have any data on that? Are you working on that?
Yes. So the original studies were conducted, as you can imagine, with all comers.
Okay.
And so they didn't need to be refractory, or they didn't need to have any previous history of failures. So the dose that we develop is, I would say that single day dosing is appropriate for the majority of the patients. Okay. We are right now starting, let's call it, it's called a phase 3B study. It's not listed in the studies there because it's part of the post-approval evaluations. We are starting a study in which we are evaluating people, specifically patients with either Candida glabrata, Candida krusei, which could be the problematics for VVC, and or those patients who have received multiple dose regimens and are failing previous dose regimens. We are also including in that study populations with immunocompromised populations, or not properly controlled diabetes mellitus, etc. That could be populations more prone to be not good responders in VVC. We are doing that study right now. We're about to start that study right now. Mm-hmm.
How much does the single dose cost?
What is considered the WAC cost, which is the kind of the cost that you put there for market calculations, is $475 for the whole dose. However, this is not the cost that anyone will pay for it, because right now, I think that, don't quote me in this one, but I think that by the end of the year, we just launched this product sometime in September last year. So, and right now we have about 40% of covered lives, which means that insurance that are already covered in our product covers about 40% of the lives of people in the United States. And there is a copay program that nobody pays about more than $30 for the whole treatment. Copay assisted program. For those who don't have any insurance, there is also a patient assistance programs to ensure that they pay a substantially reduced cost to that.
Okay. Anybody have any questions before I continue to pump David for questions? So I'd like to know, one of the hardest infections that we see to use oral is a Candida cystitis, specifically like Candida krusei, Candida glabrata. What is the excretion of Brexafunga via the urinary tract, and what levels do we get?
That's a great question. Thank you, Joey. And actually, that's a very substantial unmet need, because there is actually very few drugs that concentrate that well if it is not the azole. So when the azoles are not a good option, very few drugs have that opportunity there. The relative concentration or the relative excretion of a Brexafunga in urine is low. It's typically less than 5% of the total circulating drug. And then you could think about, well, it's not achieving adequate concentrations there. However, the product concentrates extraordinarily well in kidney and in all the tissues surrounding urine. However, really the excretion into urine is low. And as I mentioned, about 5%. However, we conducted one phase 1 study. We published that information as well, I think, in at least in an abstract format. And in that particular phase 1 study, rather than only measuring the relative excretion, we actually measure the actual concentrations in the in urine. And the actual concentrations typically exceeded the most common MICs that we see for Candida species during the 24-hour period, because we collected urine for 4 hours, 4 to 8, 8 to 12, etc. So even at the Cmax time point, we're typically at least 1 to 2-fold the MICs that we are seeing with the majority of the Candida strains. With that in mind, we have allowed the treatment with people with urinary tract infections with oral Ibrexa under our Fury study, in which other people, all patients who have not been responding to other therapies. I don't know if that addresses your question. So if you have an MIC that is within the common range, let's say with 1 microgram per ml, which is the most common highest MICs that we see. Candida albicans, we typically see much lower MICs. Candida glabrata gets to 0.5 to 1 microgram per ml. We typically cover those concentrations in urine during the whole 24-hour period with the dose that we're giving right now.
Okay. So theoretically, it should work with well, definitely, I think with a kidney, right? Definitely with a pyelonephritis.
Absolutely. For kidney, absolutely, yes, because actually the concentrations in kidney are from 10 to 15-fold higher. So the concentrations in the tissue itself are very, very high.
No, the question is in the lower urinary tract, right? Like the bladder.
That is right.
See what's going to happen there. Okay. All right. So getting back to that, as far as excretion, metabolism is primarily hepatic.
Metabolism, the primary way of elimination is actually biliary excretion. And actually the majority of the product is excreted as a parent compound. So it's not necessarily metabolized entirely. About 40% of the product is metabolized via hepatic transformation. And the primary enzyme that is responsible for that is CYP3A4. So the product is susceptible to CYP3A4 inhibitors, so it may increase Ibrexa fungal levels. However, Ibrexa by itself is not an inhibitor of those enzymes, and is not an inhibitor of any, in a relevant way, of any of the CYP enzymes, and it's not an inducer either. So it's just a substrate of the CYP3A4 enzyme. For that reason is that the potential for drug-drug interactions is relatively small, particularly if you compare versus the other drugs that are available orally, like the azoles, the only other option that you have there.
So you don't have, you don't have to adjust any dosage if you're using other 3A4 drugs?
We are, for instance, right now in the study of invasive pulmonary aspergillosis, in which we are using the product in combination with voriconazole. We actually lowered the dose of Ibrexa Fungerp to about 500 milligrams rather than 750 milligrams once a day. And the intention is to, once we complete a certain number of patients who have been exposed to that dose, we're going to do an interim analysis and do a PK assessment to verify if really that is the right dose when used in combination with voriconazole, or if we can put a little bit higher of the dose for that. So in theory, very strong inhibitors of C3A, like it could be ketoconazole, voriconazole, itraconazole. The approach that we're following right now is lowering the dose of Ibrexa Fungerp, but you don't really need to modify the doses of other drugs when you're giving Ibrexa Fungerp.
Okay. Yeah. All right. Anybody have any other questions? If not, we'll we have about 5 minutes left before we go to the final closing comments. If not, I'm going to continue and ask you, what about the efficacy of Ibrexa Fungerp in echinocandin resistant or tolerant Candida parapsilosis isolates?
So in vitro, we have little experience in clinical settings, very little experience in clinical settings. And however, in vitro, in theory, or MICs, Ibrexa Fungerp is less affected by the potential of high MICs in Candida parapsilosis. So in theory, those are one of the potential benefits that you could think about Ibrexa Fungerp over the other glucan synthase inhibitors. But I don't remember how many cases we have, to be honest, treated with Candida parapsilosis that have high MICs for echinocandins. There are not many. There are not many.
In all of your studies, there aren't that many?
No, there are not many.
Really? Okay.
No.
All right. In the Fury, I think in the Fury study,
The
there
great
are,
majority in the Fury study have been the primary pathogen that we see in Fury study is Candida glabrata, which is understood because it's the most common strain, and also it's because people are aimed for them to receive an oral option, and in many instances, the oral azoles are not the appropriate options for these patients.
right.
Echinocandin-resistant strains or echinocandin-resistant patients enrolled in the Fury study, there are some, but there are not that many. So the majority have been kind of azole-resistant strains or azole intolerant or amphotericin B intolerant cases, many of the Fury cases.
Okay. So we still need this final phase 3 study, right? What is it? The Mario
The
study?
Mario study. Yeah, the Mario
study?
study is intended really to evaluate Birexafungar in the way that we believe is going to be used in the majority of the patients, which is really patients with invasive candidiasis are most likely going to continue being treated with an IV echinocandin. The majority of them, the rate of resistance is still low for echinocandins specifically. And then once you're ready to really step down to an oral therapy, we believe that oral Birexafungar will provide an alternative option that you don't really need to worry too much about if this is an azole susceptible or resistant strain or not. And you will be able to continue, ideally, that's the vision, with kind of the same mechanism of action with an oral drug for the remaining of the treatment duration. So as you mentioned, we think that that has been the focus of this particular development program, and that is exactly what the Mario study is studying. Oral Birexafungar and as a step-down therapy. In this case, it's not in cases that are refractory or intolerant to other agents. It's, let's say, first-line therapy. You could consider those. And the other one, the refractory group, is for salvage therapy. And we're aiming to really get, ideally, both programs together to the end, so that our label and the data that is in front of you allows you to use the drug for both type of infections, as a salvage therapy, but also as a step-down therapy from an IV echinocandin. That's really the objective here.
So what is I talked about the escalation. I talked about the step down. What is in that study? When can you step down to oral therapy in your study?
The study incentivized to really step down as early as possible. We are really incentivizing investigators to really start assessing the possibilities to step down after 3 days of IV echinocandin, but in reality, the protocol does not prevent them from stepping down even earlier than that. It follows certain clinical criteria that we agreed with the regulatory agencies when to step down. You need to have identified what is the candida isolate that the patient has, because otherwise you will not know if you can effectively go into oral fluconazole or not. And these patients will go blindly into one arm or the other. So you need to know if oral fluconazole could be acceptable option for this patient or not.
Right.
And they need to be, let's say, clinically stable, which means that hemodynamically stable. Those are primarily the criteria for a patient should be able to meet prior to really stepping down to oral. Okay. And in that study, for those who are not susceptible or they are not adequate to receive fluconazole as a combination therapy, they have another opportunity to receive open label Ibrex as well.
Okay. Okay.